Today we shall be looking at cystic fibrosis. Cystic fibrosis is a chronic multisystem disorder that is inherited as an autosomal recessive trait and is characterized by a dysfunctioning of exocrine glands. In cystic fibrosis, we have abnormal mucus production by the exocrine glands, whereby these glands produce a thick, tenacious, and copious amount of mucus, leading to an obstruction in small passageways. The most commonly affected systems are the respiratory, gastrointestinal, and reproductive systems. Some of the key symptoms of cystic fibrosis are related to pancreatic enzyme deficiency and fibrosis due to a duct blockage, a development of a progressive chronic lung disease from recurrent infections, and a sweat gland dysfunctioning. This sweat gland dysfunctioning causes increased sodium and chloride levels in sweat. The diagnosis of cystic fibrosis is made through an evaluation of sodium and chloride concentration in sweat and saliva. This evaluation forms a basis for the sweat chloride test. A sweat chloride test is a diagnostic tool that we use as a diagnosis of cystic fibrosis. In this test, sweat production is stimulated using pilocarpine iontophoresis collected and analyzed. We need a minimum of 75 milligrams of sweat for us to analyze it. The normal ranges of sweat chloride concentration is less than 40 milliequimoles per liter or 40 millimoles per liter. For us to say that we have a positive result for cystic fibrosis, chloride concentration in sweat needs to be greater than 60 millimoles. In infants who are younger than 3 months, a positive cystic fibrosis test is a value that is higher than 40 milliequimoles per liter. If we have a chloride test between 40 to 60 millimoles per liter, then we can say this test is highly suggestive of cystic fibrosis and it requires a repeat of the similar test. The pathophysiology of cystic fibrosis starts from the basic defect of the autosomal recessive trait in a patient, which causes a dysfunctioning of exocrine glands and abnormal mucus secretion and obstruction of the pathways. Looking at the respiratory system, the bronchi will be obstructed, leading to a development of obstructive emphysema, and this obstruction harbors or provides a suitable environment for bacterial multiplication, leading to a development of chronic bronchopneumonias. In the digestive system, the bile ducts might experience focobiliary fibrosis with concretions, causing biliary cirrhosis, therefore leading to development of a portal hypertension. And in the pancreatic ducts as well can be obstructed, causing a secondary degeneration of the pancreas, pancreatic achilia, and a malabsorption syndrome. We believe you remember the functions of the pancreatic juice. And lastly, in the small intestines, we can experience meconium plaque syndrome, causing intestinal obstruction in newborns. When assessing these patients with cystic fibrosis, we need to perform a respiratory assessment, a digestive system assessment, and a reproductive system assessment. Let us start with the respiratory system assessment. In the respiratory system, you need to assess for airway obstruction and any infection. Remember, mucus stagnation in the airways promotes bacterial colonization, leading to lung tissue destruction, and this progressive obstruction causes emphysema and atelectasis. These patients will be having chronic hypoxemia, where we have a persistently low oxygen levels, leading to a development of pulmonary artery constriction and muscle hypertrophy, which results in pulmonary hypertension, and eventually it can lead to a development of col pulmonale. Patients who have cystic fibrosis could as well have a pneumothorax that occurs from ruptured bullae and hemoptysis, resulting from the bronchial wall erosions. Other symptoms that we can realize that are related to the respiratory system are such as wheezing, cough, dyspnea, and cyanosis. Some of the respiratory symptoms will include clubbing of the fingers and toes, a development of a barred chest, and recurrent episodes of bronchitis and pneumonia. In the gastrointestinal assessment, the earliest manifestation of cystic fibrosis is a meconium ileus in newborns who are born with cystic fibrosis. An intestinal obstruction, usually in the distal intestinal obstructive syndrome, can occur due to thick intestinal secretions that are causing pain, abdominal distension, nausea, and vomiting. The stools in these patients is frothy and foul smelling because of a malabsorption. Cystic fibrosis patients will be having vitamin deficiencies, specifically the fat-soluble vitamins, which can lead to easy bruising of the skin, bleeding, and development of anemias. They have malnutrition and failure to thrive, hypoalbuminemia resulting from poor protein absorption that may cause a generalized edema. Then we have large bulky stools and increased intra-abdominal pressures causing rectal prolapse. Pancreatic fibrosis can result due to a progressive pancreatic damage, increasing the risk of diabetic mellitus. In the integumentary system, there will be excessive high sodium and chloride levels in sweat, which are characteristic findings in cystic fibrosis. And parents in this case often report that their infants taste salty when they are kissed. We expect to have an electrolyte imbalance and dehydration, particularly in hot weather or hypothermic conditions. Lastly, in the reproductive system assessment, we will find these patients having delayed puberty, reduced fertility due to thick mucus secretion, which can prevent sperm entry, reducing the fertilities. And then most males with cystic fibrosis are sterile. They are sterile, but they are not impotent. This is due to the blockage of the vas deferens by abnormal secretions or by failure of normal development of the duct structures. The diagnostic test for us to diagnose cystic fibrosis is a positive quantitative sweat chloride test, which we have discussed earlier on, and this is the confirmatory test for cystic fibrosis. We can as well do a newborn screening using immunoreactive trypsinogen analysis and a direct DNA analysis from cystic fibrosis mutations. Imaging test can as well be done where a chest X-ray will indicate atelectasis and obstructive emphysema and pneumonias. Pulmonary function tests are quite important as well to assess the small airway dysfunctioning, and lastly we can perform a stool analysis. In stool analysis, we take a 72-hour stool sample to evaluate fat and enzyme content, specifically the trypsin enzyme, with food intake being recorded during collection. What are the interventions or the management aspects that we're going to put in place in patients with cystic fibrosis? The goal of this management or interventions is to prevent and manage pulmonary infections through the improvement of aeration, promoting secretion removal, and administering the prescribed antibiotics. You monitor the respiratory status, including lung sounds and presence of characteristics of a cough. Chest physiotherapy, such as percussion and postural drainage, every morning and evening to maintain pulmonary hygiene. Flatter mucus clearance devices may be prescribed to facilitate the removal of the mucus, and handheld percussors or a special vest device can provide a high-frequency chest wall oscillations, helping to loosen the secretions. These patients may benefit from positive expiratory pressure mask that is used to move secretions to the upper airway for expectoration. And in children, a child needs to be taught how to perform a forced expiratory technique known as huffing so as to mobilize secretions for expectoration. We can prescribe bronchodilators to open the airway for ease of mucus clearance and administer CPT when a child has reactive airway disease or is wheezing. Patients with cystic fibrosis can benefit from antibiotic therapy, oxygen therapy in case of acute episodes which require close monitoring for oxygen narcosis due to chronic carbon dioxide retention. It is important for you to know the signs of oxygen narcosis, which include nausea, vomiting, malaise, fatigue, numbness in the extremities, and substernal distress. In advanced disease, these patients with cystic fibrosis can benefit or could be considered for lung transplantation. Mucolytic medications may be prescribed to reduce the mucus viscosity and to enhance the mucus clearance, and encourage physical exercise programs to stimulate the mucus expectoration and promote an effective breathing pattern. Some interventions could be focusing on the gastrointestinal systems, and they include a nutritional requirement of a high calorie, high protein, and a well balanced diet. This diet is essential for energy and for growth. Multivitamins and fat soluble vitamins, which is what vitamin A, D, E, and K, should be supplemented as well. Children who have severe lung disease may require 20% to 50% or more of the recommended daily caloric intake, and in this case, you need to monitor for their weight and for failure to thrive. Monitor the stool patterns, assess for the signs of intestinal obstruction. These patients will as well benefit from pancreatic enzyme replacement, where we administer pancreatic enzyme within 30 minutes of all meals and snacks so that we can aid digestion. We do not administer the enzymes if the child is on a near oral intervention, and doses are adjusted based on the healthcare provider's preference, and it aims to support normal growth, reduce stool frequency to 2 to 3 stools per day, increase the enzyme doses for high fat meals as needed. Enteric coated pancreatic enzymes should not be crushed or be chewed. The capsules can be opened and contents sprinkled on a small amount of food if needed. Additionally, we may monitor for signs of constipation, intestinal obstruction, and rectal prolapse, and for any signs of gastroesophageal reflux. Other additional interventions in these patients include a monitoring of blood glucose levels for any signs of diabetes mellitus, ensuring there's adequate salt intake and fluids which can provide an adequate supply of electrolytes, monitor bone growth and development in children, you monitor for signs of retinopathy or nephropathy, provide emotional support to the patients, and provide a support to the child as well as the child transforms through the stages of growth. You need to teach the child and parents about the care that is involved and encourage independence in the child for self-care as age is appropriate for that. These patients will benefit a lot from home care, where we educate the parents and the child about all aspects of care for the disorder and the importance of adhering to the treatment, educate the science of complications, the actions to take in case of a complication, and the follow-up care after that. Then you need to instruct the parents to ensure that the child receives all the recommended immunizations on schedule, and an annual influenza vaccination is recommended for children who are 6 months and older. There is a Cystic Fibrosis Foundation in existence which provides support for individuals and families affected by cystic fibrosis. This foundation promotes the development of medications targeting the defects in cystic fibrosis transmembrane conductance regulator or the CFTR protein. The CFTR modulators are medications that address the underlying defect in the CFTR protein to improve the functioning and to manage the symptoms. And lastly, looking at the prognosis of cystic fibrosis, we say cystic fibrosis is a progressive and incurable disorder, and the respiratory failure being a leading cause of death, organ transplantations may improve survival rates in these patients.